Hi, everyone. Thanks so much for joining me on this webinar. We'll be talking about angel investing in healthcare startups. Specifically, we'll focus a bit more on diligence for this webinar. I'll give a brief introduction to myself and then we'll get going. I'm a family physician still practicing, founder of one failed startup, which was going well, had an acquisition offer, got sued, and then it kind of went downhill from there. I started angel investing after I was on the board of Halo Health with Tanasi, and Halo Health was my introduction to angel investing. I've done 5 investments so far, no exits, but no down rounds, and launched HTI as an educational platform for physicians wanting to get involved in angel investing. Sean, do you want to start us off with an intro?
Yeah, of course. Hi everyone. My name is Sean. I am a physician, medical doctor turned venture entrepreneur, and also angel slash VC investor. I began my journey similarly to Rishad in medicine, and then I quickly realized as I launched my health tech startup that I couldn't do both, and I spent a couple of years doing the health tech startup, raised a couple of rounds, and I sold it for a cash exit. And then I went on to do startup advising, had a couple of other startups that I did as well, and also invested in, which were non-health tech. And then I had an opportunity to operate for a PE firm, large PE firm, to do a health tech roll-up here in Asia. It was about $40, and we sold it for a very healthy profit. And post that, I realized the impact and the scale of going beyond just operating, and that's when I turned to VC. And so now I run a VC fund that invests in healthcare tech in Asia.
Tanasi, would you like to go next?
Sure. So I'm a physician by training as well. I did family medicine and then emergency medicine. Worked for well over a decade in the emergency department. Towards the end of that clinical career, I joined a startup called Dialogue here in Canada. At the pre-seed stage, I was a third physician or so to join, and I watched it go from pre-seed all the way to IPO between 2018 and 2021. And it was very exciting, very different compared to my day-to-day in clinical medicine. So after that, I started fairly actively learning and about angel investing and investing my own money. I also, did most of my learning through Halo Health, and then I joined the board, and now I'm chairman of the board for Halo Health, which is a Canadian physician angel group with more than 50 investments since 2020, 5 exits. I have my own portfolio as well, mostly in healthcare. And I also serve as a venture partner for a generalist pre-seed fund out of Greece called Genesis Ventures. And we get to see a lot of deal flow from all over the world, mostly digital health, and occasionally we'll do some med tech.
Thank you. Regina, would you like to go next?
Yes, hi. My name is Regina Prasad. I am based in the Bay Area in California. I started my career as a pre-med student and quickly learned that that wasn't the direction that I wanted to go down. Started my career in clinical research, worked for Johnson & Johnson, started in medical devices, and made my way over to lab and diagnostics and worked for a Canadian startup based in Richmond, British Columbia, focusing on point of care diagnostics. So manage the Western United States and all of Canada, promoting routine HIV screening and helping with our product pipeline to new 1-minute diagnostic tests. And then moved over to a startup in Silicon Valley, still in the diagnostic space, but moving more towards direct to consumer and making diagnostic testing accessible for all. I've also worked in women's health, and now I am a fund manager and investing in companies at the cross section of biotechnology and AI.
Greg, would you like to do an intro next?
Sure. No, thanks, Rishad. I'm Dr. Greg Buchert. I started life as one of the pioneers in the field of pediatric emergency medicine, and did clinical work for about a dozen years, and ran a medical group, set up hospital satellite units and a few other interesting adventures during that. And then I literally moved across the street to get involved in on the health plan side, and where I helped launch several different health plans, where I've been a chief medical officer, a COO, and then CEO for 2 plans, one of which was I started Centene's first health plan in California. And since 2020, when I dramatically failed retirement, I've gotten very much involved in angel investing, working with 2 different angel groups, both the Tech Coast Angels Orange County and Meta Angels. I've been advisor to about a dozen startup companies. And about a year ago, I actually stepped up to become the CEO for one of the startup companies, Makani Science, and we make a bandage-sized wireless wearable respiration monitor.
And
And by the way, from an investing perspective, thanks to Rishad's urging, I actually looked at, I've invested in 14 funds and have made 72 individual investments.
And last but certainly not least, Alan.
Yes, hi. Good afternoon, evening, morning, whatever we are here. So I started quite a long time ago in angel investing. I was in Silicon Valley. I'm still in Silicon Valley, like Regina, and everything was startups, right? So it had to be startups, but there weren't any in healthcare, and there weren't any groups that invested in healthcare. And so I thought that was something that needed addressed. We started a couple of friends of mine, and I started a group called 10X, which that was late 80s, early 90s. And we got to invest during the .com run up, which was really a lot of fun on the way up, I have to say. All kinds of good stuff happening and great exits until what, 1999 or 2000 thereabout. And then things stopped. And about 2003 or 4, I had stayed in healthcare the whole time. I'd been in healthcare the whole time. And it was clear that there was a lot of money to invest in healthcare. And it was clear that there were lots of young, bright entrepreneurs who had terrific ideas, who needed funding, but there wasn't any mechanism to match them. And so we started Life Science Angels. I've run that ever since. I've been a couple of other things as well. I had a venture fund with Tom Fogarty, one of the more famous cardiologists, still alive, I can tell you, at 90 years old. And pretty much retired now, but have been investing that whole time. I stopped counting at 100, but it didn't matter anyway. And I still do it, and I still enjoy it.
So we'll keep this fairly informal. I'll start with prompts, but if you guys want to jump in, feel free to jump in anytime. The one thing I'm realizing is founder commitment is arguably one of the biggest predictors of startup success. There are lots of problems in healthcare, but you have to figure out where there is a market for the problem you're solving and who will pay for it. I would love for you guys to comment on that and then maybe talk about what are some red flags you see in founders when they're pitching to you. Alan, do you want to go first, or Greg?
Yeah. I guess a couple things are, one is a lot depends on the founder. You want the passion, you want the commitment, but you also want to look at, do they have the skill set to run a company? You know, have they built company? Have they built teams? Other things like that. And so that's one of the things I look at. The other thing is, are they, especially in healthcare, are they so enamored with the science that they don't look at the business side of activities? And specifically, they can build some really neat projects, but if nobody's going to pay for it, then it could be one of those failed startups.
Alan, do you have
Yeah.
any thoughts?
I think that pretty much nails it. I would guess, let's do a show of hands. How many of us have lost money due to founderitis? Right? Okay, so first and foremost, are they going to get out of there at the right time? Right? Yeah, and they all say they will, and some do. But you've got to be really clear. It's got to be the things Greg talked about, but it's also got to be people who are well aware of what their skill sets are and are not. and who are committed that the investors and the entity be successful, not that they be personally successful beyond all else. I mean, and so it's really critical about that. And then secondly, yeah, the business model. It's that pesky, how are you going to get paid thing? And can you sell enough of them at a good enough price with enough of a margin that you'll create a profitable business that'll allow your device or solution to go to patients, make a difference in life, and ultimately be able to sell your own company. 9 out of 10 business plans we see today, even after all these years and all these incubators and accelerators, still really do not know who their customers are, and in fact what their product is and what their value proposition is. So it's a business model problem.
Any other comments?
I would just add in when we have more deep tech or med tech, we're still building a product early on that's definitely has a market need. We see a lot of technical academic founders, and a problem that I see recurrently is that they're not willing to give up their day job. So they're hedging quite a bit. I'm still going to keep my academic position 1 day a week or 2 days a week, and for the most part it doesn't work very well. For sure, there you can think of a few labs that have done it, but when you're doing it for the first time, you don't have any experience commercializing a product, it's very hard. And the other problem that I see is a lot of people that are very good academics, they can bring a product up to a certain point, but then building a team or handing over that intellectual property, it's hard to do.
Yeah, I also wanted to add another red flag being founders that are jumping on trends. So me being in the diagnostic space for the past 10 plus years, I've come across founders who are jumping on that trend of diagnostic testing, whether it be at home or even not COVID, just other commonly reported illnesses. And, they also haven't identified their market fit or where the money is going to come from, or if it's even valuable information for the patient. So yeah, a lot of attention on the product and not so much business and market.
Yeah, I think I absolutely agree with what is being said here. And I think if I could just add one small thing that perhaps is a bit more specific to healthcare. I think especially in our markets that are very nascent and pretty much in some countries is quite wild west, to be frank. The one red flag for a founder that's and we see this a lot on the pre-seed accelerator graduation cohorts and things like that. We have a lot of health tech startups that come from a place, or rather they don't come from an insider type of founder profile. And that is critical because the healthcare industry in this part of the world hasn't really moved on in the way they do things in the past 4 or 5 decades. And there are tons of legacy processes and biases that are there. And for a healthcare founder that's building into this space, or health tech founder that's building into this space, if they don't have enough insider insight, or if they don't have someone in their team that's an existing physician or a manager or operator within the space, they don't have the not just the network, but also the understanding of the nuances to be able to release a product that's meaningful for the users. And we see many of these startups get funded, and then they eventually run on the runway because they spend it all on things that physicians in this part of the world will not use.
I'll play devil's advocate.
Yeah.
Truly revolutionary products and solutions sometimes create their own markets instead of looking for an existing market. And a couple of ideas here would be a touchless EMR, which requires no clicks. And this is a known problem for every physician you'll speak with. If I can throw my mouse in the trash, I'd be very happy, and my keyboard. And we haven't really innovated on the interface in which we interact with the computer in 30 years. We still use a mouse and keyboard. And not to get sidetracked here, but what are your thoughts on a founder coming to you and saying, I will create a new market? And how would you look at that founder? How would you talk to them? And which markets would you be okay with that? And what are some ideas where, you're like, I see this gap in healthcare and people will pay for it, and this market will emerge in the next 5 years or 10 years? Um,
Yeah, I mean, maybe I can take that and then see if we have more input from the others. I think just to, I guess, clarify my position, what I just said, I'm not referring to, and look, I'm on the same bandwagon, right? We're VC, or I'm a VC investor now. And we are looking for moonshots. We're looking for people who, envision the future that does not exist, that's trying to sell apples and bananas when there's only a marketplace for oranges. And well, absolutely, right. We're looking for people who are trying to break the mold. But what I mean by nuances is by them not understanding the current play. And for the most part, you talk about touchless EMR. We talk about having EMR at all. And it's astounding to know that fairly developed countries, Singapore, Taiwan, Japan, Korea, many of these healthcare entities and places that have state-of-the-art, machines, MRIs, PET scans, and all that, they still have pen and paper, file and folder. And so there's no EMR to speak of. Doctor scribbles on the notepad, passes it down to attaches to the clipboard, and and then the nursing attendant brings it to the next station where it's to be processed. And so, like most recently in my roll-up, we were doing diagnostics as well, and 30% of all samples that get sent to the lab, they don't come out with a proper result because someone that receives the clipboard types in the wrong name, and that's ridiculous, right? 1 out of 3. So I think at least in the geographies that I'm in, it's not so much looking for the sexiest type of innovation, but the startups that make the most money are the ones that look at an existing problem that's very ingrained. And these startups usually come from a place of operator understanding. And then they say, look, this is not how we need to do this. We need to completely change it. And then they revolutionize the workflow. And yeah, I think those are the angles that we would like to have founders look at as investors, and also having that tells us that, look, you're going to go quite a long way because you understand how to play within the lines, but also push the boundaries and try to create a future that does not yet exist.
I'll add a couple of quick thoughts.
Yeah.
One is, in healthcare, I find there's often a belief that change is bad until proven otherwise. And doctors especially are very, very, very slow to change what they know, what they learned in their training, what's in vogue with their institution that they're working at. And so it's often you can anticipate a long sales cycle, even if it's a really, really great product. The other thing is that it's going to be important to talk to the right person. My roles as in the C-suite for health plans, I've actually been a very aggressive early adopter of interesting and new technologies. But I'm based in California, and so we've got this capitated delegated system where it may be a great idea, but the health plan's not going to be paying for it. It's going to be these capitated delegated medical groups, and so they're talking to the wrong person. So as they come up with these good ideas, they need to understand their market and where to even sell it.
So just a quick distinction here. I think it depends a lot on, are you spending other people's money or your own money? If you're spending your own money, you will never invest in something that's going to take 5 or 10 or 15 years to be a market. Don't do it. It's just a complete waste of money, right? You'll be capped off the cap chart several times before that place ever makes it to an exit. So for those of us who are angel investors, they better be able to articulate a market, articulate a value proposition, and a customer who is going to buy what they're selling for real money right now and be able to build a business based on it. That's that far out stuff is for funds. That's what they're there for, and that's what they're good at, and good for them. There's a role in this for all of us, but that's not a role for angels.
Regina, any thoughts?
I just agree with all that has been said.
Do you guys think the power law applies to healthcare? And based on my experience, I'm not sure if it does. Most medtech exits are between 100 and 300 million. So if you're thinking of portfolio construction, and let's assume we all run a fund here, you're looking at each investment returning your fund. Unless you're investing at a valuation sub $1 million, that's generally not possible with a small fund size, if you're not getting pro rata rates. So, is power law for non-healthcare startups, or does it apply to healthcare? And you can make an argument for biotech and pharma, which could be different. And for those who don't know, power law is a law in investing in startups that says a small percent of your investments, maybe 1 or 2 out of 20, will bring all your returns. The best investors, A16Z, they fail 50% of the times. But I'm not, just based on my short experience here, I'm not sure if it applies to healthcare. So I'd kind of love everyone's thoughts on that.
That's a tough nut to crack, and I'll try to be a little controversial in answering it. I think you absolutely have to diversify, and medtech is not a sufficient field in which to claim that you're diversified. It's a hell of a big field, as we all know, as professionals in the business. There's a big difference between a tongue depressor and a PET scan. But all that being said, the exits are what you said they are. They still take 5 to 12 years, and generally they take huge amounts of capital. There are a few breaks in there. You can do some genomics tools and some instruments type plays. Maybe you can get an 18 to 24 month takeout at a 2, 3, or 5x, which is fine. We at Life Science Angels, we also split half and half with biogenomics and therapeutics. If you only need to hit one of those, right? And so that's your sort of 1 in 100 kind of thing, but you only need one to make a difference. Those are the ones that get the big valuations in the multiple figures. Otherwise, honestly, I don't think you can make money as an angel investor solely investing in med tech. I think you would have to branch at least into tech for you to have if you're investing for the purpose of making money, and I believe that's going to be one of your questions, then I think you're going to have to diversify more broadly out of med tech. If you're investing for all the reasons that I hope we are, which is like actually trying to make a difference for human beings, then you're doing the right thing right now.
Any other thoughts on that?
For me, that's why valuation is very, very important. We tend to shy away from anything that's over 15 million post in our pre-seed or seed rounds.
Yeah, I think what Alan said,
For us,
and
that makes sense.
yeah, is for physicians, we like med tech a lot and med device because it makes sense to us. It's something tangible. But I think a portfolio based just on med tech, your returns will sort of track the S&P 500, if that, and you might as well just invest in index funds. Sean, you're laughing, so I'll have to get your thoughts.
No, I laugh because I echo the similar. I think invest in healthcare as an angel investor. Invest in healthcare because it's a field that you're passionate about. Invest in it because you see this new invention, this device that would radically change patients' lives. You know that if this gets up to market, no matter how long it takes, right? That if this fleet of products hit the market and hit it well, patient experience is going to improve, health outcomes are going to, and it's a thing that comes from the heart, right? And so I think for those reasons, invest, and of course do your due diligence and all that, and you will make some money out of it in the coming decades. But I think if you're purely speaking from a return perspective, and you want a balanced mix of ROI across your portfolio, you would do well to branch out outside of medtech and healthcare, and look at things that traditionally make money. Look at businesses that have a proven playbook. You can make your money back in 6 months, 8 months, and start profiting off it already. I would as well look to other areas that you have interest in. I think at a certain point after you've come out the medical or the clinical hole, you realize that you have hobbies and things that you enjoy, and so look to those things. If you look to innovations within that space, business within that space, and write some checks there. And I think as long as it's a business, they're looking at profit, right? And you can see that they're going to compound more. And the guys around there, you're going to make a win. You don't need an exit to make money.
Yeah, and I think it's just like other rules of investing, diversification is a good thing. And I know for my individual investments, almost all of them are in healthcare, but I know I shouldn't do that. And so that's why I've, enrolled with invested in a number of funds that have much more diversified portfolios, and in fact, often very few healthcare investments. That way I'm from the hoping to make money as opposed to helping change people's lives. That's why I try to have that kind of balance. And I always find it dangerous to spend all your time spending the people who think just like you, because I may not be right, and they might not be right along with me.
Yep. I also agree. Diversification is key. There are many industries where you can make much quicker returns if that's what you're looking for. But like many of you others have mentioned, invest in medtech, biotech if you it's meaningful for you to make an impact in the world. Or a lot of people that do invest have been personally touched by diseases that hit home with their family. And so yeah, that's my advice on that.
Thank you. Personally, about 20% of my net worth is in startups, and it seems like it will rise over the next year from the information I'm getting. Now, that makes me a bit uncomfortable from the advice I hear, which is, keep it under 10 to 15%. How do you guys think about your investing portfolio as a whole? How much of that is in startups, and then do you rebalance your portfolio as that changes?
I think some of it depends on your age. As I'm hitting 70 this year, as I'm looking at the startup investments, I'm thinking, God, maybe my kids will get rich someday because I'm not going to be around. And so I think that's going to make a difference. The other thing is that when I started my startup investing, I was very aggressive. I went higher than that 20%. But now, on an ongoing basis, I'm trying to slow down those startup investments and looking at other things that might have better cash flow, or again, looking at that diversification. So I look at my son. I keep encouraging him to be more aggressive in the startup investing than I am, because he's got a very long runway.
Any other thoughts on that?
I'll go next. Well, the S&P has been on a tear for the past several months, so by extension, the percentage I have in startups has gone down quite a bit. So it's around 5% now. It's probably going to go up for me over the next few years, but I echo the sentiment. I'm 43. I have hopefully a long time horizon in front of me. So I think it's safe. Unless you're doing this professionally, I think it's quite wise to stay under 10%. But risk tolerance, risk aversion, it's very individual.
I will say, and I think it's obvious by the members of your panel, don't try this by yourself. I think you do need to belong to a professional group like your own or like any of the ones you all have. There are best practices to investing, and just like every other thing you do in your life, there is a learning curve. Just like being a physician or a surgeon or whomever, there is a learning curve to investing. And so you really do have to understand best practices. You have to follow best practices. You have to be clear about what due diligence is and how to do it and what it means, et cetera, et cetera. So with that caveat, then I think you should, the percentage is going to depend on your age and how much money you've got.
Yep, I am a new investor, so I'm primarily investing in startups, and I'm like a few of you on the call, part of VC Labs, so learning all the best practices from there.
Regina, would love to get into your diligence process. How do you look at startups, and what do you look for from the first meeting till writing a check?
Yeah, I think the most important thing that I look for in founders is the passion. What does the solving this solution mean to the founder? Secondly, their experience with previous companies that they've helped start up, success, and in terms of, the business side of things, intellectual property, very important for me to see that they have something, the team that they built, their experience, just what progress they've made on the regulatory front, just any expertise there, legal, any compliance with marketing, as is valuation, and what they're looking for, post-money valuation. I think those are some of the most important things that I look for first.
Let's dig into IP and defensibility a bit more, especially with generative AI, LLMs, and people using these off-the-shelf models. Their tech IP, the defensibility often lies in the distribution strategy, not in their technical advantage. How do you guys think about defensibility with LLMs? Do you think generative LLMs have a space in healthcare? And I'm not sure they do. I think startups need to build their own specific use case LLMs, and where they can control what's called hallucination, essentially, where these AI models make up stuff, for lack of a better word. And sometimes I talk to founders who said, we're using this off the shelf, and the way to control that is more data. But you will not get adoption, and especially from physicians, if you're having hallucinations. And the one thing I'll say here is AI doesn't know what's important, what's not. There's no triage process in AI. So a mistake where your date of birth is wrong is the same as a mistake which says MI versus no MI. MI means heart attack or myocardial infarction. So how do you guys look at startups building on top of LLMs, and not building their own? And what are you excited about in this space?
Which of those 15 questions you want us to take first?
All of them. It was a bit of a ramble, but I realized I had a lot more to say, and the words can get jumbled sometimes. But maybe just generative AI.
I saw an interesting thing that made a lot of sense to me. I'd be especially interested to hear what the panelists think about it, since we're so heavy on the physician side of things. And essentially, the point of the discussion was that it's time for it to be tech med rather than med tech. And the premise of that was we're all focused on the med of it, and the reason that the FDA and reimbursement, this is the only industry in the world where the person who gets something isn't the one who pays for it. And so once you decouple the laws of supply and demand from an economy, you're going to have a hell of a lot of disruptions that take place because of that. And society is dealing with that now as we go through it. But here comes AI, here comes tech, and right at the time that healthcare remains the least computerized and least tech penetrated of any of the major sectors, we're seeing the ability of tech to finally make an impact on lower costs. Tech has, throughout our lifetimes, raised the cost of healthcare. Greg, I'm sure, is acutely aware of the fact that someone walking into the building telling you that they had a new device or drug meant my costs are going up. And that's what tech has done to healthcare. It is now in a position to actually bring costs down. And so I think where AI and LLM and all the other acronyms and the rest of it are going to play a role is in finding business models that lower the total cost of handling patients and patient conditions in a way that systemic costs come down and healthcare outcomes go up. And that finally we'll be able to allow the power of tech, that scalability of tech to attack a bigger problem at a better price point with better margins and lower costs will actually save the US healthcare system rather than further burden it.
And Greg, would love for you to talk about the company you discussed, if you're open to it, who have sort of figured out how to make prevention sticky, and then just your general thoughts on models of healthcare, and should health insurance pay for routine health visits where it is the only industry where we use insurance for routine maintenance.
Now, again, a handful of questions. I'll tell you, one of the things that kind of a little riff off of what Alan was just saying, I think it's helpful to have a personal investing thesis. And so for me, I use 3 criteria for looking at, will I even consider something? Is it going to improve quality? Is it going to lower cost? And given my background, is it applicable to at least the Medicaid population? Because with that, I think there's so many more challenges, and also it's a reflection of the demographic changes that are occurring, certainly in the United States and elsewhere around the world. So I think it's, that applicability is there. And I always say, is anybody who's approaching a health plan to try to get their information or their device or whatever it may be, the therapy accepted, the chief medical officer or the vice president of medical management is going to be your easiest sell. They're going to be like the people on the call here. They're going to be smart. They're going to understand how it's going to make a difference. And they tend to be more idealistic and altruistic and saying, gosh, we'll be able to save lives. But we're talking about a health plan that's a business. And so the 3 people you really need to convince are the CFO, the CIO, and the Chief Human Resource Officer, because those are the 3 people that control the resources within a health plan. And I can tell you, as a Chief Medical Officer, I know that when it comes budget time, I'm going to have to go in the fight cage with the Chief Legal Officer, the COO, the Chief Marketing Officer. Everybody's going to be fighting for scarce resources. And those 3 people are sitting up on the dais watching the blood fly as we're all trying to justify why we want our things. And, so anybody who's approaching a health plan needs to arm that CMO or Vice President of Medical Management with the details that will help them sell it to those 3 people.
Sean, I'd love your thoughts and the health insurance model in Singapore, and how do startups sell to? Is there a big health insurance industry like the States, and who are the buyers there?
Yeah, I think I'm just enjoying the conversation because a lot of this is not foreign, but it's commonly unheard of to me. In our part of the world, not just in Singapore, but for most of Southeast Asia, there is a divide between the private and public healthcare. 80 to 90%, as I was telling Rishad earlier, right? 80 to 90% of the population, they use public healthcare, which is subsidized by tax money. And like in Malaysia, for example, you can get any treatment for 1 ringgit or 30 cents US. That's with medication, consultation, surgery, ward stay, everything, for 30 cents. And that's just what do you call that? Kind of a feel nice donation to the government coffers, right? But where the insurance plays start to take effect is in the private space. So that's, I mean, that sounds small, 10 to 20% of the population, but you think about it from scale, right? You've got about 40, 50 million people in Singapore and Malaysia combined. So that's 5 to 10 million people. You know, for the most part, insurance is self-paid. I mean, corporates do cover, your employers do cover some of the cost of insurance, or they may have a basic plan, but for the most part, everybody here, myself included, you know, have personal, you know, health plans that we pay for, and these cover our procedures and costs in private healthcare. Now, selling into private healthcare and you know, as a startup, as a business, is actually, you know, luckily, it's very supply and demand. There are decision makers at the top. That, you know, as long as the hospital is using it and it's can charged onto their invoice, then it's claimable from the insurance. And so I think for especially for new devices, new things to get out to market, obviously you need some basic level of regulation to patient safety, right, to get it on the market. But beyond that, it's really how valuable your product is, how helpful it's going to be to the clinician, how effective it's going to be at optimizing business costs and all that. And I think that's where you know, you mentioned AI and LLM. And I think there's a lot of low-hanging fruit that has not yet been harvested, at least in our ecosystem here. I mean, there are solutions, but no one is monopolizing the space just yet. The first one, obviously, is in business optimization. So most recently, I was speaking with the CEO of the National Heart Association here in Singapore, and they've just rolled out. AI reporting for echoes across all their hospitals. So that means that they no longer need a bunch of radiologists and people, management, lab people reporting on all the reports that are coming out. Instead, an AI does it. And so similarly, I think across diagnostics, you have a lot of low-hanging fruit, especially image diagnostics, that AI could come in. The other one is so from the clinical side, you have I think some low-hanging fruit with not diagnostics, but in terms of clinical process flows. So we don't have CDSS systems here in Asia, so clinical decision support systems. Clinicians practice and learn from a apprentice master type of relationship. There are very few, so there are suggested algorithms for treatment, but for the most part, the consultant and the specialist decides how the junior doctors are being trained to treat. And so, you know, there is a huge opportunity because you know, defensive medicine and litigation has been climbing of late. And you know, there was a startup that I invested in 4 years ago, physician-led, that was able to tap into this, and they were the ones to launch Asia's first diagnostic co-pilot for clinicians. And this was previously unheard of, right? For doctors to, especially junior doctors who are coming in to the field into general medicine, they're sitting out there in their country clinic, and you know, the patient walks in with, you know, this disease they've never seen before. They could quickly kind of throw it into the LLM, which is, by the way, pre-trained and, you know, obviously adherent to the algorithms of the land, right? But so what happens is that the physician now has quick access to a legally sound kind of DDX, or differential diagnostic device. Obviously, you know, the physician still has to, you know, do his own clinical judgment on the patient, but having that LLM there pre-trained with all the treatment algorithms that exist in that nation, is a great help. And that has been brought up by the government here, and also by some private groups. And yeah, we're seeing a bit of a harvest coming out from that. But beyond that, not too much. But yeah, in those two areas, right, business optimization and kind of clinical diagnostic kind of low hanging fruit. I think AIs and LLMs have a space to play, and as investors, and especially physician investors, I think we are more than capable to judge which ones will come out as winners.
Yeah, I wanted to add to that list of low-hanging fruit also remote patient monitoring. I know you're talking about diagnostics, and that's my field, but I have been looking at a few companies that are in the remote patient monitoring space, and that really helps providers, evaluate trends in disease progression or likelihood in at-risk patients. And so that really helps payers in terms of reducing the risk of hospitalization. So that's where another area where AI and LLM can be very helpful.
There's tension in Canada anyways about reducing risk of rehospitalization because hospitals are not dinged for readmission rates. I don't know if that's the case in Singapore. Greg, I'd love for you to comment because you're doing this right now, about remote patient monitoring and what would buyers look for from startups, from a remote patient monitoring startup?
One is, how do they differentiate themselves from the plethora of RPM providers? Because there are a lot of companies in this space, a lot of duplication. The second thing is how much information and how valuable is the information that's provided that is, from a provider perspective, you want to be able to get information that is actionable and that doesn't overwhelm you or your practice. So you get notified if and when you need to know. And also, if you're billing Medicare, which is the big payer that's really promoted so much of this, you're getting it often enough to be able to take action, a couple times a month in order to get paid for the reimbursement. And then the other thing is, do you have devices that patients will use? And so it's it's one thing to have a device that works, that can provide the right information, but is the patient going to use it at all, and then also use it appropriately?
Any other comments on that, Tanasi?
Yeah, it's been over, at least over the last couple of years that we get pitched an RPM company every month between Hello Health and Genesis, and I haven't seen anything that has done that well in the ones that I've seen. Okay, I cannot speak about all of them, and definitely Coastal Ventures has some Cardia, which is a company that's doing really well, but I'm not very bullish when it comes to this space.
Why do you think they haven't done well?
Unless you're offering information that's objective and much more useful than what could be achieved by just having someone next to you taking your blood pressure, your vitals, and who knows a little bit about you. So a good caregiver with a phone, I don't see what the big value add. So I don't see how better they are compared to either a nurse's aide or a family member who's somewhat healthcare informed and has a phone. I haven't seen it. I haven't seen a really good value proposition to justify the costs.
You're going against lots of startups here, but Greg, love your thoughts here.
One of the more interesting companies I've seen recently tackled, I think one of the biggest challenges is that we're asking practices to operate differently from how they usually operate. It's no longer the physician who goes in room 1, goes in room 2, goes in room 3, goes back to room 1, and pulls the chart and does all those things. One of the more exciting companies I saw was a company that actually organized all those activities that have to take place in a practice in order to be an effective user of remote patient management, where they are a practice adjunct. And that was actually more helpful than a lot of the companies I've seen with the RPM solutions.
Yeah, I'm bullish on RPM solutions, if I'm being frank. I think Greg, you beautifully outlined the 3 points that buyers look for. The one I'll kind of pull on more is convenience for patients. Yeah, I mean, if a patient has a pulse ox and blood pressure cuff and a caregiver, sure. But there's a significant majority of patients who lack one of those 3 things. And if there is a RPM solution which can capture the vitals without the patient having to do much, so extreme focus on user experience and convenience for the patient, I do think there is something there. I'm also bullish on hospital at home care. Medically now has been doing this for 20 years, but now it's starting to get some traction where a lot of hospitals are delivering hospital level care at home. I wrote an article about this a while ago, which but I love your guys' thoughts on, do you think hospitals are a necessary evil and we should move care to the home as much as we can? And are you excited about this space, and will you invest in a startup that's working on this? Alan, do you want to go first?
I always get the one with 12 questions.
Yes.
Yeah.
That was 3 of them.
Well, I was just going to ask Regina a question. So this kind of pours into it. It's so that next step in remote patient monitoring and in hospital to ambulatory care to home is stats, right? It's the next thing after I get that pulse ox and temp and bloods, right? The next thing I'm gonna say is, hey, run me a set of labs. When the hell are we going to have home labs? Isn't that when we have home labs, haven't we then brought healthcare into the home? I mean, maybe Greg, you're going to have a lot of thoughts on this as well, but I've tried that twice. I've lost money on it both times. I've lost money on almost all my RPM bets. We've still got a couple of those out there. It's a business model problem. It's everybody can sell some of them to somebody. Everyone gets a pilot. Everyone has got some customer somewhere who'll pay something for some set of them, but they can't ramp and scale it. There are too many of them. There are no barriers to entry, no effective barriers to entry. And there's not enough, there's not enough margin. There's not enough what you can charge to what it's going to take to run that business for you to make any money in it. So it has to change. The answer to the question is it has to change because we're bankrupting ourselves in the US at a seventh of our economy, and the healthcare is still crap. You can't get good healthcare when you need it, and there's still errors and problems with it all over the place. So it has no choice but to change, and hopefully that change is value care rather than fee for service, and it has to go that way. But this transition to home is taking an awfully long time, and it's costing a lot of money. And there have been a lot of investments that just haven't panned out because they weren't timely or they were unable to scale effectively.
Yeah, labs have made it to the home. If you're familiar with LabCorp, they have a division called Get Labs. So they are, sending their staff to the home, collecting labs, bringing it back to the lab. But that's just like a subset of your total patient market, right? So it's easy for LabCorp to do, but very difficult for a standalone business to start up and scale up in that business.
Yeah, remote phlebotomy was an answer, but to the question of does it have to change? Look, it's better for the whole system that it changes. Hospitals, a lot of the times hospitals are being, you guys we're all in there, right? A lot of the times hospitals are being so underutilized for what they're really good for, and physicians are doing such routine, ordinary, boring things rather than the real life-changing things that they're so capable of doing, that the whole system is mismatched in terms of supply and demand. What needs to happen is the whole supply and demand curve needs to be reset. from the physician to the patient to the payer, all of it.
Greg, what are you seeing from a payer perspective in terms of home care?
I think it's, looking at Alan, we do need to reset things. And I actually think home health should probably be driving the bus instead of hanging onto the tailpipe, which is where they often are. And, the current payment mechanism for hospitals aren't set up to necessarily optimize care, optimize efficiency. And, hospitals don't get paid unless those beds are filled. Yes, great care can be provided by hospitals, and it's very, very appropriate at times. But there's a lot of care that can be provided in ambulatory settings or home settings. And so just as I think we've seen so much of care move from hospitals to outpatient facilities or doctors' offices, I think you're going to see the same thing transition from doctor facilities to home-based care. And, also that means there's roles of new types of providers that haven't been recognized in the past. The role of caretakers is critically important, and whether it be a parent, a child, a neighbor, or somebody gets paid as a personal care assistant is incredibly important. I think you're also, more likely to address things such as the social drivers of health that hospitals are not great about dealing with, things such as food insecurity and housing and all those types of things, education, employment, and those things are best dealt with in the home as well.
Any other thoughts?
A lot of this is dependent on hospitals changing, and for me to invest in a startup that wants to change the hospital and take a lot of the services provided at the hospital and bring it at home, it would have to be someone who knows the industry really, really well and has connections who can get that distribution. It seems hard, and it seems more dependent on policy than and compensation than, let's say, technology or drive and innovation. So
it's even kind of worse than that, though, isn't it? It's changing workflow in a hospital is close to impossible. And if an entrepreneur walks in with a great solution or whatever, but it's going to require a significant change in hospital workflow, are you going to invest?
I was just being nice. No, listen, it counts, yeah. But honestly, I think the best RPM company out there is Apple. If you believe in it, I think just buy Apple stock. They have a class 2 medical device that gives you status, and everyone wears it, from people worth 9 figures to people worth $1,000. Everyone likes it, and they come into my office and they say, this one said AFib, and every single time if it says AFib, it is AFib. So I'm bullish on Apple. So I think when policy changes, Apple, or Apple specifically, I think is really well positioned to provide the shovels for the gold digging.
I love how pessimistic Tanasi is. Tells me he's not once but twice bitten. Yeah, but I mean, I think personally, I'm bullish on home health. Same as you, Rishad. Simply because there is actually an incentive for hospitals to get patients out. Revenue per bed drops horridly from day 2 once the initial procedures have gone and come and gone. And there's actually one startup that I was advising and have a stake in as well, that literally built their business model off this in a very non-techy way. It's called Dr. Anywhere, ironically, and they initially started telemedicine, but that wasn't working out. And what they realized was that hospitals were having this drop off, right? So hospital CEOs were figuring out, how do I get my patients out post-op? quicker. And so these guys say, you know what, we'll do all the monitoring for you. There was you need to get the patient out, of course, case by case, and procedure by procedure. But if you hit within a specialty, you hit a couple of procedures, you cover 80-90% of the routine elective surgeries, right? And so they pitched it to a couple hospitals and the CEOs loved it. The fact was, I mean, the basic model was patient will come in for say stent, and then post stent they need to stay there for observation, right? But no, this time you go straight home, and then a family doctor would visit you from this Doctor Anywhere group. So it was pretty manual. It was pretty low tech, but what they pioneered was, at least back then, this is 4 years ago now, what they pioneered back then was the fact that there was a market for home health, and despite the lack of RPMs and all that, just very low tech, low tech manner, sending a doctor to the home, who's on a completely different payroll, has a benefit there, and the hospital managements are willing to pay a fee, which then is split, and there's still profit to be made. And yeah, they did very well with that as they scaled it across the nation, and I think now they're doing it in Malaysia as well. So yeah, I think I'm quite bullish on that, and I think as and I was listening to what Tanasi was saying, and I think I highly agree. And I had a small question. I don't hope you don't mind me, Rishad, just asking this.
No, not at all. Good.
But Tanasi, just curious, right? For all the RPM providers or founders, startups that came to you, were any of them physician led?
Physicians were part of the team. They were not the CEO. They were different roles, and none of them was full time. None of them was full time. I had some. The most impressive one was, an implantable device, which was also used, and that one I think was the best one, which was also, it gave you it gave you cardiac pressures, and it was good for heart failure monitoring. And so that one had, a cardiothoracic surgeon who would be implanting the device. It's called Acori. It's out of Europe. The rest, no, they had some advisory role, or they maybe had developed the platform initially, but they were not actively involved in the day-to-day.
Right. And that's interesting, because I think especially for RPM, for simple things like these kind of clinically linked solutions, right? A physician will know instinctively what's useful and what's not. Like you said, right? You look at the things that they're giving you, BP, pulse ox, all those kinds of, these are really basic. I don't need a fancy app to do that. I just send the patient home with a pulse ox on his finger and ask his whoever brought him to the clinic to just let me know if it's below or whatever, right? And similarly for BP sets and temperature, blah blah blah, pulse, whatever. And anything fancier than that, right? And speaking of cardio, things like Holters and things like that, those are, very specific use case patient. So, absolutely. I think maybe one of the gaps, and actually that's a gap that we're seeing as well here as a professional kind of VC investor. We're investing because we see an increasing amount of physician-led health tech startups, mostly because of the post-COVID burnout, and you see physicians leaving complete clinical work and coming into some of them do business and do other things, but a lot of them are coming into the accelerators and the startup communities because they have problems that they're extremely pissed at, and they want to fix. And so, also one of the reasons why, one of the motivations why, I set out to found the firm, because I think, in order to have money ready in the next couple of years to invest in these people, we need to start now. And so I think the timing is about right. And yeah, I am bullish on, on this side of healthcare.
A lot of startups building in the digital health space, in the AI space, don't have physicians involved on the founding team. What are your thoughts on that? And do you guys look for physicians or clinicians in the founding team or working very closely with the founding team?
I'm biased, so
Yeah.
I want them to be involved in some in some way. Not necessarily full time, but there needs to be some guidance, some access to their network. I think it's an advantage, but I think it's very self-serving of me to say that.
I always like seeing a clinical person involved somehow as on the board, as an advisor. They don't have to be part of the founding team from my perspective, because there's there's not enough physicians, and there's many people that are far smarter than any physicians. So, I've got to be, aware of that. But I think that the exposure and the knowing clinical implications, that's what I'm looking for from the physician, along with the relationship to start recruiting KOLs and help propagate a product.
Yeah, I agree as well. Some involvement with a physician, whether an advisor, full-time, part-time, KOL, champion, affiliated with a major hospital institution. I look for all those things.
It may not necessarily have to be a physician. It could be a pharma startup. So you want an ex-pharmacist, or ex whatever. But I think operator-led startups definitely is something that we do look for. I think there's a lot of learning that has already been done. They don't need to get re-immersed, right? And to try to learn from an outsider perspective. So yeah, I think we definitely look for operator-led startups, and we do favor those for two simple reasons. I think first is the nuances, but secondly also, I think healthcare operators have, and maybe I'm biased saying this, but I think they have a lot of grit. And if they were able to stick in the industry for a good amount of time, that they're not flaky, and they're not they're not as slimy as some other people might be. So yeah, so that's kind of a qualification thing for us.
Do you guys think there will be an AI scribe startup which will be a unicorn, or do you think the incumbents will win the AI scribe game? So I think there will be an AI scribe startup which will be a unicorn. I think it has to be one which develops their own LLM and doesn't have an API which wraps on ChatGPT or Cloud or whichever one.
Sorry, did you say AI scribe?
Yes, AI scribe, like
Physician scribe. Okay.
so it automates your note as you talk to the patient. There's lots of them, and it doesn't seem to be a clear winner, including Microsoft and Nuance and OpenAI working together, and Epic. But there's adoption seems finicky at best from physicians.
I don't know that an AI scribe by itself will be the unicorn. It's the AI scribe, and then has recommendations based on what's happening during the exam, and being able to research the medical history that's also easily accessible, to actually be more of a diagnostic tool, or have that augmented intelligence. And so it's not just capturing the language, but doing something with it. That would be the unicorn.
Alan, your thoughts on this?
Yeah, I think the same thing. Progress in this is now hourly. I mean, it's just astonishing the amount of capital and human resources being put on this. And interestingly, one of the I think maybe unique effects of the elements of the AI revolution is it's not just startups. Medtronic, Boston Scientific, Johnson & Johnson, they've got legions of people working on this stuff. And you can bet that the era of dumb devices is coming to an end. Right, it's all going to be interactive, connected, smart, intelligent, proactive, sensory stuff going forward. So it's just going to be now a race to connectivity and communication and platform. How the hell do we do all that when everybody's building on different platforms at different, and hospitals and physicians and practices are going to have to put all that together. But I think this is the dam has burst, and now we're talking literally within this decade.
Yeah, I agree. I think there will be a unicorn in this space. I wish I knew which one and I could access it, but it's about time. It's about time, and there's a lot of good companies, and I don't know if they're going to go public or they're going to get acquired by a bigger player, but it's about time, and it's making a big difference. Like I know people who are using it. I'm supposed to pilot it at the clinic, a Canadian one. It makes a big difference.
Do you guys have any closing thoughts for physicians and founders who are watching this right now and who will watch this later on?
I would say find your tribe and get educated. Play fantasy football for a while, and then jump in.
Thanks so much, everyone, for joining us today.